Welcome to the Spring 2013 Monroe County Law Enforcement In-Service Training, The Approach to the Violent Medical. This educational session is brought to you through a collaboration of the Office of the Monroe County EMS Medical Director and Monroe County Law Enforcement, Fire, and EMS agencies, as well as the University of Rochester Division of Prehospital Medicine. My name is Jeremy Cushman, and I'm the Monroe County EMS Medical Director, and I'm joined by Keith Beer, Officer of the Greece Police Department, and Sergeant Mark Philippi of the Brockport Police Department. Our goal through this training video is to enhance awareness of the recognition and management of the violent medical subject. Specifically, we will provide you with an overview of a syndrome known as excited delirium and considerations in apprehending and managing the violent medical patient. Our objectives include identifying the medical causes for confusion and violence, defining excited delirium, describing features and common behaviors exhibited by persons experiencing excited delirium, and identifying the pre-arrest actions to take when confronted with a subject displaying signs of excited delirium. We'll also describe techniques for containing and gaining control of the excited delirium subject. We'll identify potential limitations of commonly used control techniques, and we'll identify the post-arrest actions to take following the control of the excited delirium subject. In this first video, the officer attempts a one-on-one encounter, and it is easy to see that he struggles to manage the subject. This is not uncommon with various violent medical patients in the syndrome known as excited delirium. In the second video, despite the efforts of two officers and the use of a baton, the subject is still resisting their efforts.
Put it in paper! Put it in paper!
This was an incident in Philadelphia. This man broke into a barber shop. The store owner shot him with a gun, so he's already been shot.
Still, he exhibits enormous strength while trying to escape police officers.
I want you to notice the sergeant and all the pressure he's putting on his leg. There's no punches thrown, there's no kicks thrown, and this person is able to overpower these officers.
You understand me? You white mother... Get on the ground! Get on the ground! Get on the ground! Get on the ground!
As we'll discuss later, this video is a great illustration of the limitations of the taser in excited delirium patients. Notice that while the taser incapacitates the subject while it is being applied, the subject still fails to comply with police instructions, and as soon as the taser application is over, he attempts to flee. In this segment, notice the violent medical subject's lack of clothing, bizarre behavior, and his failure to be affected by his obvious injuries or traditional law enforcement control measures. What you're going to see as we continue today is that due to their delirious state, these violent medical subjects often don't have the ability to understand or follow commands, and traditional subject management techniques, including the use of pain to enforce compliance, are likely to fail. We're also going to discuss why excited delirium is a medical problem masquerading as a police problem, and what steps law enforcement and first responders can take to maintain everyone's safety while minimizing the likelihood of an in-custody death. Despite just over 1 million use-of-force incidents nationwide, there are an estimated 600 arrest-related deaths annually. Although this represents less than 0.1% of use-of-force encounters, the media and public response to arrest-related deaths makes major news headlines. Many of these deaths may be attributable to a medical condition at the time of the arrest, and through awareness and teamwork, some of these deaths may be preventable. So what is the classic case of arrest-related deaths? Generally, it's a middle-aged male who is agitated and belligerent. Police are summoned because of this behavior. He's then apprehended by police, where he is eventually subdued and restrained, and shortly thereafter, he goes into cardiac arrest and dies. So why does this happen? There are a number of medical conditions that can present with a subject exhibiting confused, violent, or bizarre behavior. Maybe they're psychotic. Maybe they're frankly just difficult. Maybe low blood sugar or a recent seizure could present them with agitation and confusion. In some cases, a condition known as excited delirium syndrome may be the cause, and that will be the focus of this training. Excited delirium has been called a number of different things over the years, and to date has no universally accepted definition. But for the purposes of this training, we will refer to it as a state of extreme mental and physiological excitement characterized by extreme agitation, hyperthermia, hostility, exceptional strength and endurance without apparent fatigue. Let's be clear. This is a medical problem masquerading as a police problem. The end goal is medical management and hospitalization to prevent life-threatening complications, including death from this medical condition. The end goal is medical care, not jail. So how do you recognize someone with excited delirium? They may have bizarre, violent, or aggressive behavior. They may have violence towards objects. Specifically, they may attack or approach windows, mirrors, lights, or other bright or shiny objects. The subject may be hyperthermic or have an elevated temperature and be overheating. Oftentimes, the subject will take off their clothes in public regardless of the outside temperature. They will often have excessive sweating, and they will very frequently have incoherent shouting, such as animal noises or loud, pressured speech. The subject will often have extreme and profound paranoia, which is a very common finding in these individuals. They will often have unbelievable strength and be undistracted by any type of pain, which, as we'll discuss later, may affect some of our control tactics. They often have irrational physical behavior and will exhibit the fight or flight response. They have hyperactivity in that they'll be often moving around very quickly or having rapid muscle or arm movements, and they will have an increased heart rate and blood pressure. A study done in 2009 identified that most excited delirium subjects very frequently exhibit pain tolerance, tachypnea or elevated respiratory rate, they're sweating, and profoundly agitated. Importantly, many of these subjects have noncompliance with law enforcement and will have unusual strength and will generally not tire despite prolonged struggle.
Often these folks will have a dissociation from reality, and their awareness of reality will be diminished or absent. They will not be able to associate the fact that a police officer is talking to them and may see them as a devil symbol or someone trying to harm them, and may in fact cry out for help, attracting attention from bystanders and others when their delusion is not the reality around them. The same dissociative behavior will result in these folks being unable or unwilling to comply with police orders and make them appear as though they're trying to be resistive of police, when in fact they may not accept or realize that the police are trying to address them. This will present a number of challenges to police, as normal control techniques may not be effective.
This is security surveillance video from an excited delirium incident. Notice the subject's bizarre and destructive behavior while running through the storefront, which is then coupled with his extreme strength while he attempts to destroy property and topple heavy gym equipment. In these next two videos, notice the bizarre behavior and loud, repetitive shouting, incoherent speech, and the failure to recognize law enforcement or EMS presence. You'll also notice the extreme paranoia exhibited by the individual being restrained by law enforcement and EMS. This paranoia is very common in subjects with excited delirium. The next video is from a real police and EMS counter with an excited delirium subject. As you watch the video, note the classic features of excited delirium. These include rapid breathing, extreme paranoia, repetitive, incoherent, or nonsensical speech, and the subject's attempts to overcome restraints and flee.
Yeah, that's fine.
Tim, relax.
Tim, relax. It's okay. Yes, it is.
Not okay.
It's okay.
It's not okay.
It will be okay. You gotta calm down.
Not okay.
You gotta calm down. You gotta calm down. No, you're not.
This is gonna die.
We're going to the hospital.
This is gonna die. This is gonna die.
We're going to the hospital.
No.
Tim. Relax.
No. This is gonna die though. This is gonna die though.
Remember, your mom's all worried about you. Try to relax so we can help you.
Mom!
That ain't gonna...
Don't let him kill me!
So what exactly causes this life-threatening syndrome? Well, unfortunately, there is no distinct cause of excited delirium known, and the trigger for it to occur is completely unknown. Although there are certain features associated with excited delirium, and these are male gender, with an average age of mid-30s or 36 years old, often with suspected or known stimulant use, which could be bath salts, methamphetamine, or cocaine, in some cases also alcohol intoxication. And in many cases, individuals with excited delirium may have suspected or known psychiatric illness. Although the presence of these features makes excited delirium more likely, it is not necessarily causative of excited delirium. What we do know is that excited delirium is associated with 3 key physiologic features, and it's these features that can lead to their death. Their heart rate and their blood pressure increases, their body temperature increases, and the amount of lactic acid production in the body increases. The terminal factor in most of these cases is the acidosis that develops as a result of this syndrome, similar to the lactic acidosis that we may get after exercising heavily. However, these individuals, because of their delirium, do not have the wherewithal to stop and rest. Thus, they spiral to the point that their acidosis is so severe that they can go into cardiac arrest.
Think of these folks as a car. They have the gas pedal all the way to the floor, revving the engine as hard as you can, and they have no brakes. Eventually, keeping the gas pedal to the floor, something's going to break. And that, in fact, is exactly what happens with these folks. They're revved up so much that eventually something in their system breaks. And when it fails, it's catastrophic. To use our car analogy, if our car breaks down, it means a long walk. With excited delirium, when it breaks, it means a dead person in the back of our police car or in the back of an ambulance.
The various components of excited delirium proceed to build upon each other, in that the individual may be confused and agitated. Law enforcement officer may begin to engage that subject, causing increased confusion and agitation, which also results in that individual's increased temperature, heart rate, and blood pressure, which increases their acidosis and the stress within their bodies, which then can lead to more confusion and agitation. And as you can see, this spiral can continue to escalate until that catastrophic failure occurs.
So following the restraint of this person, there also follows a typical pattern. After that, there's an apparent resolution period where the subject becomes calm or may slip into unconsciousness. You may notice that their breathing seems to be labored or shallow, and you may associate that with coming down from the fight. Following that, there may be an unexpected period of unconsciousness leading to death. Even when cardiac arrest occurs in the care of paramedics or in an emergency room, resuscitative efforts often fail. Excited delirium is not universally fatal, however. The proportion of patients with excited delirium progress to cardiac arrest and death is fairly high. Typical of those who do go into cardiac arrest do so within minutes of officers gaining control. Classically, that occurs while the person is in the back of the patrol car, in handcuffs, with their cuffs behind their back, and may in fact be unattended for a period of time. So it is very important for an officer to manage this person and to stay in contact with them at all times. Officers may believe that the person is faking or has finally calmed down, when in fact they may be spiraling down to that end point of catastrophic failure.
As we have identified, excited delirium is a medical problem masquerading as a police problem. Our goal is medical treatment as soon as possible. So to limit bad physiology, we want to avoid prolonged struggle, avoid things that impair ventilation or the ability for the subject to breathe, avoid prolonged force to the back.
Remember that excited delirium is a medical problem masquerading as a police problem. So when taking these persons into custody, consider a medical cause for their behavior based on the history and the event escalation. What happened prior to or since you arrived on scene, and how did the person escalate until they were taken into custody? We need to be certain that we're addressing the medical needs as well as the law enforcement needs, even if there are charges later to be processed. There's nothing that says we can't take this person to the hospital and address the medical first, and then the law enforcement issues second.
Expect the subject to be aggressive towards responders. Generally, expect one of two responses. 1, they will fight you. 2, they will flee from you or fight to flee. Avoid a one-on-one confrontation. You're unlikely to win. Usually able to overpower 1 or 2 officers, sometimes 3 or 4. They likely have no remorse, no fear, and they feel no pain. Officer safety and pre-planning is crucial. Contact EMS early so they can start with medications. When the decision is made to go hands-on, have a plan and go 100%. Wait until help arrives, if possible. So stressing the management of these subjects, as we've already said, avoid confrontation if at all possible. Attempt to contain and isolate the subject without confrontation, limiting their movement if at all possible. Evacuate any other bystanders, and attempt verbal de-escalation. Have as many backup officers as possible, and request EMS to the violent medical prior to the confrontation, if at all possible. We may be hesitant to call EMS directly into the scene prior to the subject being subdued. It's important to understand that in these situations, we have a subject with a medical problem masquerading as a police matter. And this may be one of the few times where we need to have EMS come into the scene, control it to the best of our ability, whether through containment or triangulation, and be able to brief them so they understand the plan prior to going hands-on. We're not trying to dictate any type of policy or to remove officer discretion. We're trying to demonstrate that in this circumstance, we may need to think outside the box and use a team approach to managing this type of subject.
Given that excited delirium is a medical condition, its management is through the use of sedatives. Sedatives, such as the benzodiazepine known as midazolam or Versed, or dissociatives, such as the medication known as ketamine or Ketalar, can be administered by advanced life support personnel. These medications can be given through an intramuscular shot or through a nasal spray. The decision to use the shot or spray is made by the paramedic and primarily depends on access to the subject and the safety of administering the medication via that route. However, again, it's important that the decision of which route the medication is given is made in a team fashion between law enforcement and EMS. Communication is key, as all responders need to know which medication is being given and how it is being given. Unfortunately, these medications may take time, upwards of 3 to 5 minutes to take their full effect, and therefore, just because the medication is administered does not mean that other restraint or control techniques should be given up until it is very clear that the subject has had the effect of the medication as intended.
Remember, when summoning EMS, to say the words violent medical. This immediately triggers the dispatcher to send an advanced life support or paramedic ambulance with the appropriate medications and to send them on an emergent response. It's important, too, to make sure that you clear with the dispatcher whether you want the ambulance directly to the scene and how to enter the scene. Are they to come in through a particular door? Are they stage outside the door until you are able to brief them? Or is there a particular staging area that has been set up based on the position, triangulation, or other management of the person's movement? If you're in an outside scenario, there may be areas that you don't want the ambulance to enter due to crowd control situations. So be clearer that when you call the ambulance, you want them into the scene or that you want them to stage in a particular area. And when they arrive, make contact with the primary medic and brief them on what's going on to the point wherever possible.
As excited delirium is a medical problem masquerading as a police problem, appropriate physical restraint to manage the patient's medical problem is paramount. That physical restraint should allow access to the patient, including the potential for achieving intravenous access, allows the patient to ventilate and breathe effectively as well as dissipate heat, and is secure. In some cases, the restraint method shown here can be augmented with the use of handcuffs to the backboard, but generally handcuffs affixed to the gurney are not recommended. In some cases, EMS providers may carry and consider application of a spit sock to decrease the amount of projectiles from the subject. If this is the case, the patient should be monitored continuously once that spit sock is in place.
In this scenario, law enforcement and EMS are together in a team fashion and are ready to apply a takedown technique that will result in the person being brought to the ground face up, and EMS can move in a relatively rapid fashion. In this particular situation, you'll see that the subject in this demonstration has not continued to resist. Understand that the 4 officers who are now managing this person are each managing a limb, and EMS is moving directly in so that the person can be moved from the floor directly to the backboard. In this situation, the person will likely be struggling with police, so it's important to maintain that 4-point control over each of the limbs. Allow EMS to move in when appropriate, get the person directly onto the backboard, and then you'll see EMS is immediately applying a thigh leg strap. When applying the leg strap should be placed so that it is above the knee and over the thighs and cinched tightly to secure the legs from any movement. That allows us then to move into restraining the torso and the upper body. The chest strap should be applied as high up on the chest as possible and under the arms. In a position where it is actually slinging or supporting the arms, it should go across the chest tightly, but not so tightly as to restrict air movement or the movement of the lungs. Controlling the legs and the thighs first is key. Keeps the person from kicking and bucking against the officers. It also keeps the torso on the backboard and allows management of the upper body more effectively. You see, the EMS is applying soft restraints, but handcuffs could be applied as a temporary restraint. When securing the arms, the subject's left arm ideally should be placed down along their side to allow access to the EMS providers to provide medications. And the right arm should be placed above the head, again to the topmost strap points on the backboard. This also will allow the best securing and the best access for EMS. A spit sock is applied to keep the person from spitting on providers during the restraint procedure.
We recognize that EMS may not be present when officers achieve initial subject control, nor will subjects always be this cooperative. But now that we've showed the ideal restraint method for violent medical subjects, we'll concentrate on considerations for getting the violent medical under control and transitioning them to medical care when waiting for the arrival of EMS is simply not practical.
Management of these subjects when they're displaying violent, bizarre behaviors will most often require some form of police confrontation and restraint. The restraint is the end result, as control is the end result of any subject control situation. So we want to end the fight quickly and effectively, and gain control as effectively as possible. Remember, when managing the subject's joint movement, joint immobilization is key, but pain compliance aspects such as wrist locks and pressure points will likely be ineffective. Maintain control of the joint above and below long bones. So the forearm, try to maintain a wrist lock and an elbow lock. Get them into a bent arm bar or a straight arm bar where possible, where you can maintain control of the bone above and below the joint. Maintain control of all 4 limbs independently if possible, and consider someone being assigned to just the head to manage the torso and hips and the legs as well. Choose a technique that will result in the quickest restraint with the minimal amount of fight. Remember, pain compliance techniques may not work. Taser is an option, but in neuromuscular incapacitation mode, not drive stun mode.
Medical studies have very clearly demonstrated that the taser does not cause any dysrhythmias or injury to the heart itself. It does not impair breathing. It does not induce any type of respiratory or metabolic acidosis, nor does it cause any clinically significant rhabdomyolysis or muscle breakdown. Thus, an individual that has received a taser discharge should be managed just as any other individual with excited delirium.
Remember, after application of the taser, that the person is going to be able to fight that initial neuromuscular incapacitation off and rejoin the fight. Their tolerance to pain is fairly high, and they are not going to respond to a drive stun or the pain aspect of taser as effectively as you might expect. Therefore, it's important to apply the taser and attempt to control under power. We train to this, and we talk about this during our training for taser. Just remember that we want to avoid, if possible, prolonged or multiple simultaneous taser discharges. What this means is you may hold the trigger down for longer than the initial 5 seconds, but be mindful of how long that's being held down or of multiple discharges, as this can, in effect, cause exhaustion in the subject. We want to avoid the chest shot where possible, the low center mass is the target of choice in the front or in the back where possible. And again, drive stuns are not going to be effective. Taser is still not a substitute for the hands-on application of physical force. And that may mean that when the taser does not appear to be effective, we need to move to another tactic. Don't keep pulling the trigger if the taser is not working. There are a number of reasons for taser failure, and those include bad probe connection or simply too many clothes. And that's the case, you need to realize it as a taser operator and move in with a swarm or other tactic. We need to understand also that the techniques we typically use to gain control may contribute to making the excited delirium syndrome worse. That's not to say that we don't apply these tactics. We just need to be aware of that and to quickly apply the EMS side to this. We don't need to change our DT practice. Just be aware that once this person is under control, we need to address the underlying medical issue. Remember, through ground stabilization, we're going to have this person in a face down, arms behind their back, handcuffed position. Often a three-point landing requires the person to have a knee or a part of your leg across their back in order to keep them down and under control while we're handcuffing. These positions can, in fact, create more problems for the person as they try to breathe through their excited delirium. So we need to be aware of this. Again, not change tactics, but once the control is gained, get them on their side and get in a better position. Lay them on their side. You can still control the legs and body without putting pressure on the chest or back. Assign an officer to control the head. Keep the subject talking and watch their breathing. If they suddenly slow down to the point where they're no longer talking to you actively, watch to see that their chest is rising and falling. And if it looks as though they're starting to have difficulty, don't wait. Get EMS there quickly. You'll need to maintain control of the body and their movement while making sure that they can breathe and blood can reach the brain. You also need to search during this time, so having an officer at the head to monitor breathing and body movement while the other controls the legs and initiates a search can be an effective use of resources.
In this next scenario, you'll see demonstrated a face-down takedown of an excited delirium subject, along with handcuffing, a cuffed recovery, and then movement to a backboard. The officers take the subject down. You can see the officers each move to one extremity so that control is applied. The subject is handcuffed. Communication is obviously key. Observe the individual at the head who is coordinating all of the activities while maintaining proper scene safety and requesting for EMS. Once the handcuffs have been applied and the appropriate handcuff tension has been checked, the subject is then rolled onto his side into the recovery position, and the subject can be monitored for appropriate breathing. From this recovery position, there is absolutely no hurry once the individual is controlled appropriately to move the individual to a police car or to some other type of area. From this position, the officers can take a minute to gain their breath, to slow down, and to continue to de-escalate the individual. The individual can also be searched for weapons prior to turning him over to EMS. At this point, EMS is then called in. Once EMS arrives with their appropriate equipment, then we can transition from police subject management to an EMS medically managed patient and control techniques. The individual can be moved to a backboard, and then appropriate EMS-friendly securing techniques can be used, including the use of soft restraints. Only after the individual is properly secured by these techniques will then the handcuffs or other law enforcement restraint techniques be removed. Recognize that handcuffing the individual behind his back may be necessary in the initial law enforcement management until the individual is able to be moved to a backboard. Understand that maintaining handcuffs behind the individual's back when placed on the backboard is generally not recommended. This is not to say that handcuffs should not or will not be used to handcuff the individual to the backboard. Again, this is not to tell officers not to use their discretion in managing the subject based on what they think is necessary for the situation at hand. At this point, have a plan in place with the EMS providers and communicate how you will transition to soft restraints, or to maintain handcuffs but handcuff the individual to the board, or soft restraint the individual to the board in a one hand up, one hand down technique. This accomplishes two things. One, it reduces the chances of positional asphyxia, and two, provides the EMS providers a proper and easy area to be able to manage the individual with medical techniques. As a review, for our subject management, once control is gained, ensure that the subject's breathing is not compromised. Move the subject to a backboard, and then work with EMS to restrain in a manner that is safe for all. One officer will likely need to ride with EMS, and it is practical to have an additional officer at a minimum to follow the ambulance. An easy way to remember the steps for managing a violent medical can be used with the mnemonic ACES WIN. A, standing for Alert Dispatch, request resources in EMS for the violent medical. This should trigger EMS and the dispatch to dispatch an ALS ambulance. C, contain and restrict the subject's movement. E, evacuate bystanders. S, speak slowly and quietly to the subject. W, wait for backup and EMS to arrive. I, instruct all responders on the plan. And N, engage the subject 100% once the plan is in place.
This video is a real-life example of an excited delirium case that is outstanding in that the subject demonstrates many of the features of an excited delirium patient, as well as the responsiveness of law enforcement in recognizing that this is a potential excited delirium case, summoning emergency medical services, and using team care to elicit a good outcome for the subject.
Auto gave me 911.
Hi, something's wrong with my son. I'm on 1103 South Jefferson. I don't know whether he got, he's 29. I don't know whether he got onto something. He's just, very strange.
Okay, does he need an ambulance? What are you reporting?
I don't know. He's just talking and talking and saying he's going to die, and he's just making like he's on something. I don't know. You hear that?
Does he live there?
Huh?
Does he live there?
Yes.
Has he been drinking?
I just got home a little while ago, and took a shower. He was sleeping. I think he must have.
Did he use drugs?
He used to. He hasn't for. He used to do marijuana. He hasn't for years. I don't know whether. I don't know. I don't know what's happening.
I mean, he keeps yelling and says he's dying. Does he say anything else?
No, he just says, I'm dying, Mom, and he's sitting there naked. He certainly doesn't do that in front of his mother.
9128 and 9218.
9128.
9228.
You can help out with a southern complaint. RP's 29-year-old son is acting strange. He's yelling and does currently not have any clothes on. No weapons, unknown intoxicants, unknown drugs. Keeps screaming that he is dying. He's breathing heavily and has no clothes on. Code 3.
9102.
Go ahead.
Dispatch Gold Cross, non-emergency at this point, just a stage in the area. Give them the behavior signs we have at this point. I'll be around as well. Can you talk to your caller, just see if he has any past drug history or mental illness history?
9102, the only thing the RP is aware of is he used to use marijuana years ago.
Okay. I'll be in the area.
I'm clear.
What?
Pull me all with 102.
Hi, it's okay. It's okay.
As I'm not.
It's okay.
As I'm not. This is the last heartbeat.
It's okay. It's okay.
But I'm going to
I understand.
Isn't gonna die, but I'm going to. Isn't gonna die, but I'm going
You're
to.
okay.
Is I'm going to die.
9102, restrict traffic.
Beats.
Counselor at Appleton,
But
channel 1 is restricted
It's okay. What is his name? Tim?
die.
Tim, we need to go to the hospital.
But I'm going to
9102.
Wow,
Have
and
Gold
this is
Cross
a
come up
really
to the
big
address.
one, because I'm
1033
not
at this
die,
point.
But I'm gonna hear the heartbeat.
Yeah.
Of
What's his
me
first
saying,
name again?
Oh, I'm going to die.
Tim.
But I'm going to lay down on the ground.
Can you lay down
as
for me?
I'm going to die. But
Tim.
I'm going to
Tim.
not, and you understand now. And isn't that fucking weird? But I'm going to.
Tim.
I'm gonna die. But I'm gonna look around. As
Tim.
if I'm gonna die, shivers are gonna kind of running up my
Tim,
side.
it's okay,
And I'm
ma'am,
not gonna be
ma'am,
able to say
ma'am.
that, but you're gonna
At
know
this
what
point,
I'm
let's just
gonna
put the
mean.
clothes away.
And I'm gonna
Okay,
lay down
this is
on
a
the ground
reaction
with
to
my arms
something.
shaking
Okay,
to
we'll
make
get him
it
to the
look like I'm
hospital.
really-
9102. The Buys Gold Cross, I believe we have an excited delirium case. I need them here.
This one's gonna happen, and I'm gonna fart. Really gonna happen. This is gonna happen.
Tim, it's okay.
Last time I didn't know this was.
Just relax, man. Just relax.
This is really gonna fart, and I'm gonna happen in that hand right there, and I'm really gonna fart in it. And this one, wow. And the heartbeat is coming.
We get two to the back and kind of come in that entrance, officers. Okay, in case we have some movement. I think what we're going to do is if we get those two to the back and get them in here, once we do go hands, they're probably going to have to go to the feet, and then we'll get them on board. We have the medics ready?
Yep.
Okay.
They're at the sideline.
All right. All right, let's move. Okay. All right, just relax. Okay, get the medics up. Let's get him on, strapped down to the cot.
In this demonstration, officers initially responded for a domestic disturbance in an upstairs apartment. When law enforcement officers arrived, they identified an individual exhibiting bizarre and abnormal behavior that could be consistent with a violent medical subject. As a result, law enforcement officers summoned additional law enforcement assistance, as well as identified to dispatch the request for EMS for a violent medical subject. In this circumstance, the subject was able to be contained without risk to bystanders or officers until EMS arrived, again reinforcing the ideal circumstances for managing these individuals, which may not always be present. You'll also note that EMS and law enforcement had identified a plan in advance that included restraint and the administration of a sedative using a needle. As you'll see, communication between law enforcement and EMS is clear. The patient is transitioned to medical care and moved to the ambulance and later the emergency department for the treatment of their medical condition.
Don't kill me, man! They're coming to get me! Get off of me now! Get off! Don't kill me! Don't kill me! No, go away! Go away!
Come on in.
No! I got short.
You're all right. You're all right.
Get off me!
Meds are in.
Get off me!
Give a couple minutes to calm down here.
Okay.
You're all right. Relax. Relax. You're all right. We'll give it a second, guys. And then we'll help us move him up on the bed. Got it. You're all right.
Get off me!
We got
Get
it.
off me!
Ready?
Get off me!
Ready? 1, 2, 3.
Get off!
You're all right. Relax. Calm down, Mike. Calm down. You're all right. Relax. Relax. Good over there. Yep. All right. I've got his arm. If you want to get forward.
Don't kill me, man! Get off!
No one's gonna kill you.
No, you're killing me!
You're all right, Mike.
I don't want to go into space!
You're all right.
Get off of me! Get off! No!
1, 2,
Okay. Hand over. There we go. Alright. Yep. Don't kill me!
You're alright, you're alright.
Don't hurt me!
We're taking care of you.
Where's my dogs? Where's my dogs?
Dogs are alright.
Dogs!
Alright.
The aliens took them last week.
Relax, Mike. You're gonna be all right. You said about 3 to 5 minutes, right?
Yep, starting to calm down a little bit.
Mike, calm down. We're taking care of you, Mike. We're taking care of you. Just calm down for us, alright?
You guys got the gurney right outside the door?
Yep, well secured on this end.
I'll see you in that end.
Yep.
Alright.
Okay, on 3 we'll pick them up.
Alright. From the top to the bottom.
Everybody got a little wrong?
Alright.
Alright, on 3. 1, 2, 3. Yes. Hold on, wait a minute, Ben. There we go, alright.
Watch his arm run down?
In summary, our key points that we would like you to remember. Understand that there may be medical causes for confusion and violence. Recognize features and common behaviors exhibited by persons experiencing excited delirium. Initiate pre-arrest actions to include additional officers and EMS when confronted with a subject displaying signs of excited delirium. And once control of the excited delirium subject has been gained, initiate medical management in cooperation with EMS. We recognize that we have provided a best practices concept of managing the violent medical. We also recognize that some of the techniques here and the order in which they are done may not be realistic for every situation. The key point is to have a plan, to brief everyone on the plan, and then execute the plan as safely and as quickly as possible, and to understand that these individuals are medical patients masquerading as a police problem.